Senior associate editor at The Atlantic, Rachel Gutman, did a deep dive into Paxlovid, the COVID antiviral drug, in a recent Atlantic article. The first data on the pills came out in November. President Joe Biden called the drug a game changer, while the data hinted it would cut the risk of hospitalization by 89%. Now the government has ordered 20 million courses of Paxlovid, giving half of the $10 billion in additional COVID funding that is being debated in the Senate. This is according to Gutman's reporting.
As we are focusing more efforts into this drug, however, confusion around its effectiveness as well as side effects are also rising. Some have reported experiencing a second round of symptoms and have also tested positive for COVID after taking the drug, a phenomenon that has become known as Paxlovid Rebound. Joining us to discuss what we know about Paxlovid and all of the questions we still have is Rachel Gutman. Rachel, thanks so much for joining us.
Thank you for having me.
Yeah, thanks so much for joining us. This is a really important discussion to have. So talk to us about what your reporting has shown. And in your view, what is the legitimacy to these concerns about Paxlovid?
For sure. As far as legitimacy, I mean, when it comes down to it, the only published data that we have from Pfizer is in unvaccinated people who are at high risk of severe COVID, and all of their data was collected during the Delta era and not Omicron. So we have very little direct data from Pfizer itself about how well it's working in the population that's receiving it right now, which is both unvaccinated and vaccinated people who are at risk of developing severe COVID. And during the Omicron era, there are two different Omicron subvariants that are circulating right now. We did get some data yesterday out of Israel that looked at Paxlovid in a more diverse population, so both vaccinated and unvaccinated people. And it found that in people over 65, you can still have a pretty significant reduction in risk of hospitalization and death. The reduction was 67% for hospitalization, 81% for death. But for people ages 40 to 65, they really didn't find any significant difference in outcomes between people who took Paxlovid and people who didn't.
So I think a lot of people might say, okay, it might not have an effect, but so long as it's not causing harm, fine, it's worth a shot because it is effective in certain populations and depending on the variant at large. But what is the deal with Paxlovid Rebound? What is the implication of people who take the drug having then been diagnosed as positive for COVID afterward?
Right. And I want to point out that also hospitalization and death are not the only benefits that you can, or reductions in hospitalization and death are not the only benefits that you can get out of a COVID antiviral. If it reduces symptoms, if it reduces your chances of long COVID, those are worth considering. And we just don't have the data on that yet. Long COVID data by definition is going to take a long time for us to get. But in terms of Rebound, basically what's happening is people take the drug and some number of days after they finish their course, usually within about a week, they start experiencing symptoms again. They start testing positive again. We don't know if that is actually more common in the population that's taking Paxlovid versus just the general population that is coming down with COVID. In the clinical trial, Pfizer found that only about 2% of people who were on the drug experienced rebound, and it wasn't significantly different from people who weren't taking the drug. But it's possible that with this new variant, all the subvariants of Omicron, that proportion could change. And it might be that people who are taking Paxlovid are experiencing rebound more often, or it might just be that everybody's experiencing rebound more often, whether or not you're on Paxlovid because of something to do with the new variant.
That's interesting. Because it could just be the variant and then, well, but then even in that case, it would seem that Paxlovid's the really good case, or the case where Paxlovid is doing the most good, is if you're entirely unvaccinated and you're up against a severe form of the disease and you're maybe in a risk category, then, Paxlovid, there's a large window of help you could get from something like Paxlovid. But if you're vaccinated, if you're not particularly at risk, then you're not really seeing such a differentiation in your experience, right?
That's what seems likely. Again, we don't know about things like symptom resolution and prevention of long COVID. But in terms of things like hospitalization and death, if you're vaccinated, if you're boosted, if you're under 65, your risk of that is already fairly low. And so there's not necessarily much that Paxlovid can then do to lower your risk. All we have right now in terms of data on real people in the real world during the Omicron era is that study out of Israel, and that has not yet been peer reviewed, but that did indicate that there's really not that much benefit for people who are under 65.
Well, and right now they're not generally giving it to people unless you fall into a risk category. I just went through this. I was ill earlier this week. I went to the doctors. I did not test positive for COVID. I tested a number of times. And then the doctor said, well, if you're curious, you can continue to test at home. And I said, well, if I have a positive test, then would you actually prescribe me this? And she said, no, because I don't have a immunocondition, or I'm not older than 65. So I guess that guidance then, based on this research, makes some degree of sense.
Right, definitely. The interesting thing about the research out of Israel is that it didn't really necessarily show that if you're under 65 and also have these compromising conditions or are at risk of some kind of severe complications, that it would help you. So it's possible that the sort of eligibility criteria that the US has laid out are still broader than would strictly benefit from the drug. We just don't know.
And do we know anything about how doctors are prescribing it now? Because just anecdotally, again, people have described instances where their grandparents, loved ones who are older and do fall into some of these risk categories still were not prescribed Paxlovid, at least in earlier moments when perhaps it wasn't as accessible. Do we expect there to be any guidelines promulgated as to when it should be prescribed so that people can anticipate more specifically what they're going to have access to if they want access to it?
I can't say what the CDC is thinking and whether they're planning on changing their guidelines. I can say that just anecdotally from folks I've talked to who have been on Paxlovid or attempted to get Paxlovid, there is sort of a discrepancy. Some doctors are erring on the side of prescribing it to as many people as they can, and some doctors are feeling more cautious, especially in vaccinated people, because again, they didn't have the data to prove that it was actually doing any good in vaccinated people until yesterday.
Very interesting.
Part of the problem is that we're just not tracking really who's getting it. The HHS only recently started posting data on how many Americans have been prescribed Paxlovid overall. It's over 1 million as of yesterday, but we don't know exactly who's getting that in terms of where they live, what their demographics are, how old they are, what their income is, all that kind of stuff.
Very interesting. Well, Rachel, thank you so much for explaining that to us. We really appreciate it.
Thank you for having me.
We'll have more Rising right after this.